Recently, there has been an increased interest in mouthpiece ventilation, as patients see the benefit of it. Some of the advantages of mouthpiece ventilation are the fact that it allows the face to be free from mask or headgear, it facilitates speech, eating and drinking, and so allows for a better social life. In the recent literature, there's quite some data that show and support the usage and the safety of mouthpiece ventilation. Let's take a closer look at some of the most relevant and up-to-date articles around mouthpiece ventilation. Hello and welcome to this introduction to mouthpiece ventilation. During the next few minutes, I will give you an overview of some of the literature that is available about this way of applying non-invasive ventilation. The usage of mouthpiece ventilation for patients with Duchenne muscular dystrophy has been recommended by the American Thoracic Society in their consensus statement, which was published about 10 years ago. More recently, the Canadian and the British Thoracic Society have also advised to consider the use of MPV as a potential tool for non-invasive ventilation in this patient population. One of the first articles describing the use of intermittent positive pressure ventilation via the mouth was published in the early 90s by John Bagg. In this large patient review, Dr. Bagg concludes that MPV can be an effective alternative to tracheostomy for individuals with adequate bulbar muscle function but chronic respiratory muscle insufficiency. He also points out that access to reliable and effective manual-assisted cough or mechanical insufflation is key for a long-term success. Another important paper was published by a Belgian group in the European Respiratory Journal in 2006. In this publication, Michel Toussaint and co-workers study 42 Duchenne patients and look after the long-term impact of daytime MPV on survival and lung function, and also after the impact of daytime MPV on daytime CO2 tension and related symptoms. In this rather large group of Duchenne patients, they were able to show that CO2 levels improve with the usage of MPV in a similar way as with other NIV techniques. And also long-term survival rates that are reported after 1, 3, 5 and 7 years of MPV reached values from 88 to 51%. Overall, this study shows that mouthpiece ventilation during the day, as an extension of nocturnal ventilation, is safe and provides reliable survival in end-stage Duchenne muscular dystrophy patients. And the authors conclude that daytime ventilation via a mouthpiece can be recommended on the condition that patients are equipped with a self-supporting harness around the neck, as indicated by the red arrow on the photo, and that they have access to non-invasive techniques for airway clearance. In 2013, Douglas McKim and his team in Canada report their experience of 12 Duchenne patients who combine nighttime NIV with daytime mouthpiece ventilation and present the benefits to patients and the safety of using 24-hour NIV. Adding MPV rather than continued daytime nasal ventilation allows the face to be free from an interface, to engage in normal verbal communication, and to breath stack for airway clearance as desired. MPV offers the patient and the family effective management without the surgical risk, the long-term complexity, and the additional nursing care required with tracheostomy management. It's to be noted that the authors also mention that the consistent use of long-volume recruitment techniques and the usage of mechanical insufflation has contributed to the long-term success of NIV and the small number of hospital admissions. McKim and his team conclude that while tracheostomy ventilation may be necessary in patients with DMD with severe bulbar impairment or with cognitive impairment, most Duchenne patients are quite capable of using MPV. And that for Duchenne patients, a strong consideration should be given to 24-hour NIV MPV rather than routine recommendation for tracheostomy. In a very recent publication that looked at the effectiveness of mouthpiece ventilation in real-life situations, it was shown that disconnections from the ventilator occur frequently. And as you can see on the graph on the right-hand side of the slide, the disconnections during activities such as eating, making a phone call, or watching TV are associated with an increase in CO2 and a decrease in SpO2. These findings support the usefulness of educating patients about behaviors that can induce hypercapnia or oxygen desaturation, and also indicate the importance of using an external warning system or ventilator alarm based on the minimal minute ventilation in order to prevent blood gas abnormalities. In this paper, published in 2014 in Respiratory Care, Sonia Kirani analyzes the practice of mouthpiece ventilation. The publication consists of two parts: a bench test, which looks at the technical performance of 6 ventilators available on the French market, and a clinical survey and questionnaire, including 209 patients with a neuromuscular disease. Out of these 209 patients, 30 patients, or 14%, was using MPV. For this overview, we will focus on the feedback and answers from the patients rather than on the technical specifications of each of the tested ventilators. The patients report a reduction in dyspnea as the most important benefit, followed by reduction in fatigue. Facilitation of speech and eating were rated as the third and fourth most important benefit. Other reported advantages were better vision, reduction in skin injury, and facilitation of swallowing. When one analyzes the patient characteristics, it's clear that this study shows that mouthpiece ventilation is used in highly ventilator-dependent subjects, as the daily mean duration of NIV was 19 ± 6 hours, with 15 out of 30 patients using NIV for more than 20 hours a day, and 11 subjects using the ventilator 24/7. And as the authors state, the results of the survey confirm that mouthpiece ventilation is effective in postponing invasive ventilation by tracheostomy. In this article from Respiratory Care, Dr. Carlucci and Dr. Grigoretti give guidance to the reader on how to make the appropriate settings on different commercially available ventilators when using MPV, and how to avoid nuisance alarms during MPV. They also stress some important facts on how to improve and make MPV more comfortable for the patient. One of the key factors, which they point out, is the necessity of a very low flow in between the breaths, as both the noise from the flow as well as the flow itself may create discomfort for the patient. An element where the Vivo 50 scores really good compared to some of the competitive devices tested in this paper. It's also important to mention that for this bench test, the authors used the Vivo 50 without MPV mode, as this mode was not available at the time of the study. Therefore, the limitation of the IE ratio of the Vivo 50 was still applicable and caused some limitations around the actual setting range that could be used in the study. Of course, this has now been solved with the launch of the MPV mode in the latest version of the Vivo 50 and 60, and the ventilator allows now for an independent setting of breath rate and inspiratory time. In 2014, Nicolini and co-workers published their results of the usage of MPV in 50 subjects with COPD exacerbation and mild to moderate acidosis. As you can see on the graphs in the slide, they found that both groups had similar trends in arterial blood gases over the first 48 hours of NIV application. Further, no differences in breathing frequency duration of NIV, or hospital stay were noted. However, a significant difference in acceptability was found. The patients clearly preferred mouthpiece ventilation. As the study is only looking at the short-term application of MPV, one should not extract the results to promote long-term MPV for COPD patients at this stage. But still, the study by Nicolini gives us an important clinical message. Mouthpiece ventilation may be considered as another tool in our armamentarium and as an alternative to other interfaces in case failure of NIV is caused by poor tolerance of the mask. For the last part of this review, we will take a closer look at 2 review articles which have been published recently and mainly point out the advantages and disadvantages of MPV. Let's look at a disadvantage first. The most important disadvantage of MPV is that it's predominantly to be used during the day, and it's harder to use at night. Both review articles contain important information on when not to use mouthpiece ventilation, and they state that mouthpiece NIV is not successful when patients are uncooperative, cannot access the interface, or when a severe bulbar dysfunction causes aspiration of saliva such that the O2 saturation baseline remains below 95%. When we look at the advantages of MPV, it's clear that both articles point out that MPV delivers good quality of ventilation with the benefit that it has less negative impact on the patient's social life, has no risk for skin breakdown, and facilitates speech, eating, and drinking, and so should be considered for patients who require daytime ventilation. I hope you liked this introduction to mouthpiece ventilation. If you want to know more, please visit our website at breas.com and find more information on the clinical section. Thank you.